How do we go about getting someone diagnosed? Let's say that same person that is in your chair getting his teeth cleaned, Guy, and your hygienist says, how are you sleeping? Are you tired? At times you don't want to be. Have you been told you snore? And it's their first exposure to that. Where do we go from there? As a dentist, how do we get them diagnosed?
I have this opportunity more than Rich because Rich's practice is solely devoted to sleep apnea for 10 years now. I do have a general dental practice, and that's a good question. And the answer is it used to be we had to send them in for a polysomnogram, and that's basically a full test in a lab that in a facility other than their home. It's been the standard of care for many years, and it's a very good test. The problem is to get a patient who's in to have their teeth cleaned or something like that, they may agree to go do it, and I see them 6 months later, oh yeah, I'm going to get around to doing that. Basically, in my office, I found about 1 out of 3 I could actually get to go get the test. What's happened in the last couple of years, another big change for dentistry, is home sleep testing. It's become legal, if you want to call it, acceptable and paid for by insurances. Now, with the availability of home sleep testing through your primary cares, maybe you can help implement it some in your office. So if you work with a physician, you can make this process very easy where they can get a test in their own home. The key thing I think is important is we should not be making oral appliances on anyone unless they've had a test of some sort, along with the help of a physician, because snorers are pre-apneics, we don't know where they are until they've had a test.
Absolutely. You're exposing yourself to some type of liability on several levels if you do that. So we're certainly supporting the help of our colleagues and physicians, and we don't want to cross that line where we're actually practicing medicine. We do what we do best. But as dentists, I hope that you're starting to see we are the healthcare practitioner that sees the most adult patients every year and that has the best opportunity to ask about these things and start to screen them. When somebody goes in and has a sleep study, these are the types of things that you might see when you get a sleep study back. You're not supposed to be able to read this, but we're looking at pulse oximetry and muscle movement and effort and snoring and EKGs, what's happening to the brain, as we do this so that we can do sleep staging. So when patients have a sleep study, there are other things that can be diagnosed besides sleep disordered breathing. And that's why we need our physician colleagues to help us out here. So, Guy, go over these definitions for us real
Well, I
quick.
think this is important if you're going to get involved in this, and this is really the nuts and bolts of what you need to know, the basics. And they're just terms you may not be familiar with. I know when I started in dental school, dental morphology was awful scary to me because I didn't know what mesial and distal meant. Well, this is just the same thing. And the basics are, what is an apnea? Well, apnea means cessation of breath. Basically, to be defined as an apnea, we're measuring the airflow going in and out of a patient's mouth, and they quit breathing for 10 seconds or longer. It could be 20 seconds, 15 seconds, or 40 seconds. But that's defined as an apnea. A hypopnea is a decrease in oxygen flow for at least 30 seconds with a resulting decrease in O2 saturations of at least 4%. So basically, if you think of an apnea, if you recall the airway a tube, that's a complete closure of the tube. A hypopnea is a squeezing of the tube or constriction of the tube, but they both cause the same negative ramifications. And then a RERA is something that really doesn't fall into either one of those categories. It stands for respiratory effort-related arousal. But basically, you see a person that's sleeping and their brain waves are sleeping in nice, maybe delta REM sleep, and all of a sudden they come out of that deeper sleep into lighter sleep, and that's associated with some disruption in the breathing, but it doesn't fall into those two categories. And that's what a RERA is.
Gotcha. And the hypopnea is a 30% decrease in flow, the air. It's kind of like a restricted labored breath. When we talk about defining sleep apnea, we have to put numbers somewhere. What's your cholesterol? Is it too high? Is it too low? We have to draw the line somewhere. So 5 to 15 events per hour would be considered mild sleep apnea. 15 to 30, more than 30 being severe. So we add up the apneas, we add up the hypopneas, we index them per hour. That gives us an AHI, and this is a measure of the severity of the disease. I see some of you are sending your questions in, and somebody just sent in a great question here that I think we should address, Guy, about the difference between an AHI and an RDI.
Yeah, I guess we didn't adequately define that. Again, to make sure that AHI is the apneas and hypopneas divided by hours of sleep. So if you have 50 apneas and 50 hypopneas and you slept for 10 hours, your AHI would be 10. Now, what an RDI is, which we don't have on the slide defined, it's basically the same thing. It's the apneas and hypopneas, but you add the RERAs to that as well. So it's the apneas plus hypopneas plus RERAs divided per hour sleep.